This webinar is meant for us, for medical workers, and the aim for the webinar is to continue raising awareness about lupus and to share the experience by our eminent speakers who will talk to us about lupus and various aspects of it. So this afternoon we had the privilege of having a public webinar where we had the members of the public, patients, and family members and others who joined us, and we had excellent talks by both our patient support group, the chief physiotherapist, our rheumatologist, Professor Oyo, Dr. Genga, Dr. Lawrence Owino, and we had candid discussions about lupus covering different areas. Dr. Fred Otieno, who ran us through what is lupus, pediatric lupus, Dr. Owino. We went through lifestyle about lupus and COVID-19, but this was general information for the patient. And this evening, we are honored to have you all and have this medical session for World Lupus Day 2021. And you're most welcome. And the aim, of course, is to improve awareness. As I mentioned with our earlier public webinar, and this webinar is meant for medical workers. As medical workers, of course, we all know what lupus is, that lupus is an autoimmune connective tissue disease with variable presentation, commonly it's commoner in women of childbearing age, but it's a disease that may occur even in the elderly, in male patients, and even within our setup here, we have many male patients. But mine is not to give a talk on lupus. Mine is to welcome you to this evening meeting and to invite our eminent speakers. Our first speaker will be Dr. Angela Mcgowan, who works at the Aga Khan University hospital in Nairobi. She's a pediatric rheumatologist. Sorry for the typo. She's an excellent pediatric rheumatologist with a keen interest in care of children with rheumatological conditions. She's widely published. She's a teacher and trainer. The second is Dr. Genga, who is a lecturer at the university. She is a physician and rheumatologist, teacher, trainer, researcher, many publications already in his young age. He's doing great stuff. And of course, we have the father of rheumatology in this country, Professor Omondi Oyo, who we all know is a professor of internal medicine. He's a consultant physician and rheumatologist, who will give us a talk on arthritis and lupus. Dr. Genga will give us a talk on updates in lupus management. Dr. Mcgowan will give us a talk on pediatric lupus. We have Dr. Beril Ganda, who is a physician rheumatologist at Moi Teaching and Referral in Eldoret. She's an excellent physician there, doing great work to support rheumatology care in the wider Rift Valley region. And she'll give us a talk on pregnancy and fertility. So mine now is to invite Dr. Beril Ganda. Mine now is to invite Dr. Angela Mcgowan to proceed on and make a presentation, which is a pediatric lupus. As I mentioned, we had an earlier on session on pediatric in lupus, but just for the public. But now Dr. Angela Mcgowan will make a presentation to us. Now she can share a screen with us.
Thank you so much, Dr. Tao, for that kind introduction. I'm unable to start my video and share screen. I don't know if the control room can assist with that.
Mwenda and Amina, kindly assist us with this. I was also not able to share my video.
Okay.
And
noted, Dr. We are working on it.
Okay.
Are you able to allow Angela to share her presentation?
Yeah, you can continue. I'm working on it.
Okay.
Yeah, we have enabled. She can start sharing.
Okay, Angela, kindly share your screen.
Okay. Let me see if I
Let me stop share mine.
Okay.
Yes, now you can proceed and share yours.
Okay. Then now let me give it a go. Just a minute. Okay. So share screen. All right. Are you able to?
Yes, we're able to see you. Angela, please proceed.
Okay, you can also see me? Because I'm unable to share my video, but well.
Okay, it's fine. Please kindly just proceed with the presentation.
Okay.
Thank you.
All right.
Yes.
So thank you once again to the organizers of this session for giving me the opportunity to actually make this presentation. And I want to honor each and every one of you who have logged in to make time for this session to raise awareness for lupus. So this is the title of my talk. And those are my objectives: to familiarize clinicians, I had a quote to begin with by Nelson Mandela: "Do not judge me by my successes, but judge me by how many times I fell down and got up again." Sometimes when you manage lupus, especially in children, it can be a bit demoralizing because you try and figure out the problem, but it can take some time. But that's why we are having this session. So the objective of this session is to familiarize clinicians on how to clinically identify suspected cases of pediatric SLE. And secondly, to initiate management strategies for patients with pediatric SLE. And that shall be the outline of my presentation. So SLE has been described as the prototypic autoimmune disease with a vast array of clinical manifestations. And the hallmark of this disease is that you actually form antibodies against components of your cell nucleus. Tiffin et al. In 2014 did some work at a conference that was held in South Africa, trying to find out how many countries had publications on lupus. And you can see South Africa was leading the pack with 35, and then the next set of countries that were leading were those in North Africa. And we had a publication from Kenya and a few others from the West African region. And this was a survey she did with healthcare workers. She then inquired at this conference how many of them had seen new cases of lupus and how many of their patients had died because of lupus. And you can see there's a correlation, like for example, in South Africa, where they had more publications, they were seeing more cases, and the black circle represents the number of deaths. So the larger the circle, the more number of deaths. The larger the circle, also in color, the more cases they were seen. And this hallmarks the importance of raising awareness to empower other healthcare workers to identify cases of lupus. So what actually goes wrong in the disease process that would result in somebody presenting with lupus? There's often a genetic predisposition, and this genetic predisposition predisposes you to have uncontrolled production of apoptotic material. Some of the genetic reasons that have been implicated are abnormalities, for example, in your redox reactions, abnormalities in the cell death process. And when you have that genetic predisposition in the backdrop of certain environmental triggers, like infections and ultraviolet exposure, radiation exposure, this offsets a cascade of uncontrolled production of apoptotic material. Because most of this material is held very well confined within your cell, particularly the cell nucleus, your innate immune cell kicks in because it realizes here there's danger. There's exposure of certain aspects of the cell that should not be exposed. So we need to move in to try and contain this danger. So in the spirit of trying to contain this danger, the dendritic cells try and mop up this apoptotic material, and the immune system is so wonderful, nobody works in isolation. They call for help with your T cells. So they present that material to the T cells and tell the T cells, we need help here because there's something going on that we can't contain. And then your T cells will communicate with your B
Dr.
cells.
Angela.
Yes.
Sorry, can you
Yes.
kindly start your video?
Okay. I was unable to do so initially. Now it's okay?
Now you're fine.
Okay. All right. So I was at the point where I was saying that then your B cells get information from your T cells, then you produce antibodies, all aimed to mop up this excess apoptotic material. So you've got these antigen antibody complexes, immune complexes, which again offset a cascade of inflammation. So see, you've got this uncontrolled inflammation that is happening literally everywhere from head to toe because your nuclear material exists everywhere from head to toe. Okay. So what are some of the clinical features that we anticipate in children with lupus? And this cuts across the board, children with adults also. There's a saying that lupus has 1,000 faces. It can look like anything because you potentially have inflammation going on in every aspect of the body. So it could be something as very subtle as mood changes. Other times it can be poor concentration or very overt things like convulsions. You could have sores in the nose or the mouth, bleeding tendencies. You could have prominent lymph nodes. Remember, you're having this B cells and lymphocytes being stimulated to try and help other cells of the immune system to contain this uncontrolled inflammation. You can have a pneumonia-like picture, hepatitis-like picture, nephritis kind of picture. Of course, you can have arthritis, myositis. I mean, the list is endless and a whole array of skin manifestations. The same Tiffin et al. In her survey in 2014 looked at what are some of the common symptoms that would present in our continent. And what was found to be one of the most common is actually arthritis, followed by renal manifestations, serositis like pleuritis, pericarditis, ascites, and very rarely would you get symptoms like antiphospholipid syndrome, for example. So now we're going to appreciate some clinical manifestations. So this is what, for example, a Malala Rash would look like among our population. You have got this duration of the skin, and this is important to distinguish just from malaerythema because of sun exposure. Malaerythema, when you palpate it, it will not feel indurated and swollen. Remember, we've talked about the inflammatory process, but in this case, a Malala Rash, if you palpate it, it actually feels indurated and swollen. And it typically goes over the malar eminences, over the nasal bridge to the opposite side, sparing your nasolabial fold. One of my favorite areas to inspect in a patient I suspect has lupus is the palate, because they would have a palatal sore, which is painless. So the patient doesn't know it's there because it doesn't hurt. But for us, if you don't look, you will not see. They can also have an array of many lupus rashes. We looked at the Malala rash, which is an acute rash. Then sometimes you can have what you call the chronic lupus rash. And these are rashes whereby there's initial inflammation and then they heal with scarring. In this picture, you can see there's some element of a Malala rash, but you can see also there's a rash over the eyebrow. And even look at this at the earlobe. And in this case, it was healing with scarring. There's something we call lupus perneal, where you have got induration and inflammation just at the tip of the nose. This is a case of discoid lupus rash, whereby they had the rash with scarring and alopecia. Sometimes that's another sign which can happen even several months before other manifestations come up. I recall the first patient I met, a pediatric patient with lupus in my training. She had presented with what looked like an appendicitis. They did the surgery, but the histology was unremarkable. But when we took the history, 3 months before she got her abdominal pain, she had alopecia. Her hair was just falling off. Another example of lupus rash, and you can see here how it's going to heal with scarring. This often is misdiagnosed as eczema, but you know very well this is not very typical distribution for eczema. Look at that other example of a not Malala Rash, sorry, this is a subacute lupus rash. This is a rash whereby, yes, you can see there's erythema and inflammation, but when it heals without scarring. So that's an example of a subacute rash. Look at another example of a discoid lupus rash, where you're at the center, you could see that area that looks almost necrotic, and when it would heal with a scar. Another example of a Malala rash over the malar eminences across the nasal bridge, sparing the nasolabial fold. Other variations of Malala rash. So it's not always nice and uniform. It could be a bit patchy, but you're looking at the general distribution. Another example of a subacute lupus rash, whereby you have got erythematous margin and like a target-like lesion at the center. And when this one heals, it heals without scarring. You could also have lupus gangrene, whereby you've got this inflammation that is also happening at the level of blood vessels. And you can imagine if there's inflammation at the level of blood vessels, there's potential for that to be obliterated. And that affects the blood supply to the extremities, and you have gangrene. Another issue you could see with lupus is they could have antiphospholipid antibodies. And so you could be throwing emboli. Again, that blocks your blood vessels, and you have gangrene. And I've actually seen like about 3-4 cases of children with lupus gangrene. Other times you just have a vasculitis, and you can see features of that at the tip of the fingers. Other things that you could see is what we call Levator Reticularis, and this is because you're having inflammation in the veins, and because of that inflammation, there's not enough good flow through the veins, and you have got backlog and stasis, and then you have got this reticular mesh-like pattern that forms on the skin. This is an example of somebody who presented with alopecia. That was one of their early signs. This is an example of somebody who had lupus and presented with a vasculitic rash. And what's classic about vasculitic rashes, they're like red patches, but when you apply pressure, it doesn't blanch, all right? So that can give you a clue that you're dealing with a vasculitic rash. So we're going to go through some very quick cases. So this was a child who was referred for management of arthritis. And one thing I'll tell you about arthritis in children, it is not a diagnosis on its own. It's like a symptom, you know, like telling someone your blood level is low. If I tell you your blood level is low, you have anemia, I have to tell you why. Is it because you're not feeding well, or are you bleeding somewhere, or is your bone marrow not working well, for example? So it's the same thing for us as pediatric rheumatologists. When we get children who have arthritis, we ask ourselves the question, why? So she was sent to me for management of arthritis. But when I took the history 2 months prior to that, she had had hair loss and a loss of appetite and this popular skin rash that was treated as eczema. The key findings on examination was that she had a temperature of 40.5. All the other vitals were fine. And the rest of the examination, what was standing out was the Malala Rash. And so what did we do for her workup? We asked for a full hemogram. I have to say this is one of my favorite tests because I look for leukopenia and lymphopenia. She had an elevated protein creatinine ratio. We were concerned about lupus when we found the ANA was positive. Her complement C4 was low. And so with looking at this entire picture, we were able to make a diagnosis of lupus in a child. Oh, this was a catastrophic case. This is a child who apparently was well until November 2018, and she just had swollen fingers. They thought she had a throat infection, was given Augmentin, and things were fine. She went to bed December 3rd, 2018, perfectly fine. And on December 4th, 2018, she woke up completely blind. When we asked the ophthalmologist to review, he found what was classic or rather pathognomonic of lupus retinopathy, which was this like cotton wool spots. Unfortunately, she deteriorated very fast, ended up being in ICU for 6 months because now her respiratory muscles were involved, but we were able to salvage her with immunosuppressive therapy, and she's doing very well. This is an example of lupus gangrene, that child who came to me all the way from Kisumu. And her problems actually started in 2016, and she had this particular rash, which was just treated with steroids and IVIG. And one of the things I plead with all those who are logged in, when you see some of these symptoms, the question is always to ask why. Why are they presenting with these symptoms? So that was treated with steroids and IVIG. 2018, she presents with fatigue, knee swelling, finger swelling. Then she develops breathlessness in 2019, treated for pneumonia. They went to India. They came back. I don't know what happened, and they didn't seem to get a diagnosis. She came back home. We did the workup, and her hemogram showed anemia. She had proteinuria, hematuria, several antibodies positive, and we treated her for lupus. So when it comes to diagnosis of lupus in children, we use similar criteria as those used in adults. Before, we used to use this criteria that was developed in 1982. Then we moved on to SLIC criteria. This is what I used in my training. But now this is the criteria that we are using. And the key thing is that you should have an ANA positive 1 in 80 minimum, and should have at least a minimum of 10 points. So you look for all these signs and symptoms, and also in your labs, if they add up to 10, you're able to make a diagnosis of lupus. The principles of management in lupus, and this is where my colleagues are logged on, you're very key in the care. One is to prevent lupus flares. And the way to do that is to encourage them in sunscreen protection. If they can't get sunscreen, they wear a good hat and long-sleeved clothes. We manage the comorbidities, so we vaccinate where we can. They often have low vitamin D and calcium. Our steroids don't help them in this, so it's important to supplement this. Advise them on healthy living. We know lupus is a pro-inflammatory condition, so it puts them at risk of cardiovascular disease. So healthy living, eat healthy, exercise, and of course, ultimately definitive treatment. And benchmark, just as in adults in treatment, is hydroxychloroquine. Then we add on other disease-modifying anti-rheumatic drugs, depending on which organ is involved. If they have predominantly arthritis, we give methotrexate. If they have predominantly hepatitis, we give azathioprine. And what is very exciting for us in rheumatology are the biological therapies, where we actually give medications that target specific inflammatory cytokines. Like now, there's a lot of excitement about tocilizumab because of COVID, but I can tell you rheumatologists have been using this drug for the last 20 plus years to treat many other diseases. I think at that point, I'm happy to take questions, but just to summarize, diagnosis of lupus in children requires both clinical features and relevant investigations. The skin, musculoskeletal, and renal system are the most common in children, but the renal and CNS are very severe with very high risk of mortality, and management requires a lot of multidisciplinary care and tailoring treatment to specific lupus features. And with a quote by Julius Nyerere, who said, if real development is to take place, the people have to be involved. If we are to make a change for children with the lupus in our country and across this continent, each and every one of you who have logged on are very key in this noble agenda. Thank you.
Excellent presentation, Dr. Angela Mcgowan. Excellent presentation. We'll take questions at the very end of the presentations. Right. So please stay on. I'm sure questions will be flowing, and we have a good time. We'll spend about maybe half an hour or thereabout to answer any questions that will emerge from the presentation. Thank you very much for that. Now, our next presenter is Dr. Eugene Genga, and he's going to present for us today. He's already on the updates of Lupus 2021. basically what's new in the management of lupus. So we'll give him adequate time so that he can enlighten us on what is new. Welcome, Dr. Genga, and we are ready to listen to you. Dr. Genga, you can unmute yourself. Dr. Genga, you are not mute. You are still muted. Okay.
Can you hear me now?
Yes, yes, we can. Please proceed.
Okay. Sorry about that. So, thanks, Dr. Atawa, for organizing this forum. I was given a very broad topic, so I thought I would pick on just specific aspects of what is new, what is exciting, what has a lot of application in terms of management for lupus. So, as an outline, we'll look at some more on what the current treatment goals. A question which I'm normally asked by my patients, I'm sure most of you also asked about the role of hydroxychloroquine. Can we safely take them off? The prednisone question, how low is safe? Can the patient survive without the prednisone? Then something smaller than what are the new novel therapies, and a conclusion. So lupus, a lot well matched with this. A lot of people assume this is a disease that's found outside Kenya. But we have a lot of papers coming out, done mainly by registrars in Kenyatta. We've also done a few. Typically, what's the usual presentation? A young female presents with polyarthritis, hematological issues, cutaneous disease. It's always wise to look for lupus in such a patient. In this particular paper that we did, the time that we diagnosed is about 0 to 13 years, which is a very long time. In the States where they have better access to medical care, there's about 6 years. In terms of how are we doing, this was done by Nyambane. Actually, 50% is done in Kenyatta. 50% of our patients are actually moderate to severe disease, which is not a very good thing. And also in terms of the quality of life, it affected the physical health, pain, was a burden to others, body image, and the general health. And what they found are the patients who had low quality of life was a sort of active disease, a younger age, recent diagnosis, and a renal disease. And as you can see, majority of the drugs, actually 14.5% were not on medicines, but majority of the patients were on at least some form of disease-modifying therapy. Something very alarming was about half had some sort of renal disease. Of these, some were actually on single clinic, for example, either on follow-up in the rheumatology clinic alone or the renal clinic alone. And some of the recommendations she gave from her study was that we should have more combined clinics because there's a lot of diversity in terms of how the drugs are being prescribed for our patients. So we'll go straight to the gist of the topic. A very common question is, what are the patient priorities? It was directly published in the ACR last year, and actually a lot of the patients in the States in this particular paper had showed high rates of satisfaction with the current therapies, even though despite the high treatment burden. Of significance is that the patients considered fatigue, pain, and pleasure the most important treatment goals. So I think as rheumatologists or people who are actively involved in rheumatology care, I think these are areas which need to be taken a lot into. Usually fatigue and pain are very difficult because at some point differentiating between lupus pain from fibromyalgic pain is a problem. Flares are a lot to do with education. Tell them as soon as they get infection, see a doctor. Sunscreen, which Angela has already mentioned here, things that take for granted. The sun can actually activate the lupus and all that. Vaccinating our patients, these are some of the things we should need to do, educating our patients about. So in terms of an ideal target, take for example, like high blood pressure. Hypertension is blood pressure, diabetes is sugar. So what would be the ideal treatment target for lupus? Would we want for remission? Would we want low disease activity? Part of the challenge we've had is how to assess this particular treatment target. Some of them are disease-oriented, meaning overall, and some are organ-directed. As we've come down with the lupus, that the disease is very diverse. In terms of type, for example, a patient with lupus nephritis, usually that's a very severe case, even neurolupus, vis-a-vis somebody who just has cutaneous lupus. So sometimes comparing the two patients becomes a bit of a challenge. So in terms of targets, low disease activity or remission, generally, actually from this particular paper, this was also published in the ACR in the 2020, the target, they're saying that if you're able to get at least low disease activity is acceptable, where remission is not possible. And we're saying in terms of any benefit, yes, it prevents damage accrued from SLE. So it's something which can be applied to our patients, because sometimes we really want ideally remission, but sometimes that can be a problem. So low disease activity can actually be an achievable target. And in terms of does it protect against preterm birth in lupus? Not exactly. There is evidence about low disease activity and preterm birth, but at least it prevents things like miscarriage. So for patients who you are not able to, in terms of accomplish remission, at least 6 months prior to conception, at least the recommendation from this paper was that at least having low disease activity is enough, at least, but you have to advise the patients appropriately that the risk of preterm delivery is actually higher in such a patient. So in terms of low disease activity, there are many tools, but you want at least no new activity, no major organ activity, but more importantly, the use of prednisone. A lot of patients usually abuse this particular drug, and they recommend at least less than 7.5 milligrams per day. On that, at least we are sure you're on at least a low disease activity. So speaking of prednisone, sorry, I like cartoons. Growing up, my small sister liked this particular cartoon. It's from the mermaid. As you can see, she has the signs of stereotoxicity, the sparse hair, moon face, obesity, and those are some of the issues we have with prednisone, and that direct level treatments can actually cause about 80% of the damage directly when used in the wrong setup. So the question would be, what is the safest dose for prednisone? Is it 0? Is it 6? Is it 10? Actually, from most of the literature reports out there, actually about 0 to 10 is acceptable. This particular paper showed 0 to 6. At least you can see the risk is actually better. But also anything above 10 has an increased risk of cardiovascular events. So I think the recommendation is anything below 10. Preferably, if they can, you get them off the medicine. So the other question is hydroxychloroquine. This usually is a very uneasy question. I'm sure for most rheumatologists, the patient is stable, has not had any flares in a couple of months. So the thing is, are we safe to take of the medicine? Because usually patients get fatigued from taking the medicine over and over and over. So this is actually presented also in the ACR. And actually from what they gather from this particular paper is that reducing or discontinuing hydroxychloroquine vis-a-vis continuing hydroxychloroquine was actually associated with a poorer outcome. So the hydroxychloroquine has a lot of benefits, and sometimes good as a doctor or a clinician to explain the benefits to the patient, from protecting the kidney, protecting the heart. So there are so many benefits associated with the hydroxychloroquine. So ideal is that, but sometimes you may be forced in terms of, can you safely withdraw? This was also presented in the last ACR, American College of Rheumatology, and where they're comparing between patients who are abruptly withdrawn vis-a-vis patients who were weaned off. And actually, patients who are weaned off actually perform better than those who are abruptly withdrawn. The only question would be, how do you wean them off? Is it over 3 months, 6 months? As you can see, there's still many questions that are lingering. And I'm sure with time, maybe we'll be able to answer that over time, but not now. Okay. So in terms of what is new for the lupus treatment, it's very interesting to know that over the in 2011, actually, that's the first drug was approved for lupus after more than 50 years. And why is that so? Because lupus is a very difficult disease in terms of its expression. It's very heterogeneous. It's not like a disease where everything is the same. A patient have lupus nephritis, another can have lupus, another may just have skin manifestation, another may just have antiphospholipid syndrome. It is very, very diverse in terms of the pathology. The disease activity is also intermittent. Today you're stable, tomorrow you get a flare. So sometimes gauging becomes a problem. Another thing is lack of an agreed disease activity measures. As you can see, some people push more for organ specific, others push more for disease specific, because as you can see, the disease is very diverse. And even the costs involved in terms of making these particular drugs for such a rare disease is very astronomical. It can go up to 1 billion. The thing is, probably they'll say in terms of profit margin, 1 billion for about a few hundred people. In terms, it doesn't make a lot of business sense. So as you can see, there's a lot of challenges in terms of why it has taken so long to develop new drugs for lupus. So in terms of what is approved, aspirin is approved, steroids, preferably low dose, hydroxychloroquine, and belimumab. But we have standard care, which involves azathioprine, methotrexate, mycophenolate, cyclophosphamide for the very severe, tacrolimus, not that much, but can be used, and rituximab, which I'll explain further in the later slides. So just I'll not go much to this because Angela has already mentioned this, but it's important that we remind ourselves the pathogenesis of lupus, because at each particular target, step, is a potential target for intervention. We know there's issues to do with the defective clearance of the apoptotic material, which leads to activation of the B cell pathway, the T cell pathway, leading to immune complex deposition. From that, into activating the inflammatory cascade, the B lymphocyte stimulating factor, the complement, interferon. So all these are potential targets. From the B cell has been targeted, the T cell has been targeted, B cell with the B lymphocyte stimulating pathway has also been targeted, interferon, which I'll discuss further, has been targeted, complement also has been tried to be targeted. So I'll start with the drug that caused so much excitement in terms of the lupus world, was the first drug that was actually approved after more than 50 years. So in terms of how does it work, it actually targets the B lymphocyte pathway. And the B lymphocyte pathway actually helps in promoting B cell, promote differentiation, proliferation, and survival. So in theory, if you block that particular pathway, the autoreactive B cell pathway undergoes apoptosis, thereby reducing the immunological process and everything, thereby controlling the disease. So the question would be, how do you translate what is in theory into practice? So two landmark studies, the BLISS-52 and BLISS-76. As you can see, in terms of the countries where people are participating, Asia, South America, Europe, North America. Unfortunately, Africa wasn't represented here, but in terms of who they included in the studies, the patients who had high disease activity. SLED is a disease activity index. So the higher the score, the higher their disease activity. And patients who had positive ANA and a positive double-stranded DNA, and they randomized different doses for the belimumab. And actually, when they followed up these patients, actually they showed improvement in terms of musculoskeletal complaints, mucocutaneous issues, hematological, immunological, and renal. And most significant, renal is what really brought a lot of excitement, because when they did a post-hoc analysis, in terms of flares from renal were reduced, and proteinuria actually went down. So this is actually one of the drugs that can actually be safely used in terms of lupus nephritis. Is it available in Kenya? Yes, it's a bit of a very expensive drug. I don't know how much it costs in Kenya because I'm yet to prescribe it here, but from the internet, it may cost about 1,500 per dose, and it's usually a weekly. Can give us twice weekly, can be subcutaneous or can be an injection. You can see it can be a very costly drug. So in terms of more information on the lupus nephritis, another paper actually looked at in terms of if it can be used as an add-on therapy. And actually from what they're looking at add-on therapy, they're looking at the lupus nephritis class, at the same time the race, and what are the outcomes, they're looking at in terms of flare and improvement of the patient, and then actually reduction of steroid dose. And as you can see in almost all parameters, there's actually a good improvement. The most especially was seen in patients who are mycophenolate and patients who are class 3, class 4 lupus and nephritis. And also blacks actually were covered here also. So one major drawback, the belimumab is not all clean. It has an increased risk of psychiatric events, especially the IV formulation. Though from this paper that was done in the ACR also, and the 2020 ACR, it showed that the risk is not as initially that people are feared, but it's still advisable to counsel the patients, especially patients who seem to have an increased risk for depression, psychiatric issues. These are patients who need to talk to them and tell them belimumab may increase the risk. Thereby they are aware. But the good news is that most of these things will probably resolve once the treatment ends. So rituximab is another drug. Rituximab usually has been tried in hematology for everything. Remember, people stuck through it. But in terms of evidence for lupus, to be honest, the trials have been very, not been that successful. Explorer looked at non-renal lupus, Luna looked at lupus nephritis, and to be honest, the outcome wasn't as good as expected. There were some issues with the study design. In terms of one, the drugs that were in the background, there's a high dose of steroids, immunosuppressants, so you're not able to tell it's due to the immunosuppressant and the steroids, vis-a-vis the rituximab. At the same time, the endpoint using mild flare, which was not, which wasn't the best, because there are actually a fewer patients who had severe disease. So, but largely, impact of direct hasn't been successful, though in terms of refractory, it may have some benefits. And actually, that's where we use it a lot more, because in terms of getting response rates, it's actually better in refractory lupus. So in terms of as first-line therapy, not that much, but refractory, it may have some benefits. So another drug that has come into the phase, the obinutuzumab, it targets the B-cell pathway, just like rituximab. It's actually a B-cell depleter. As you can see from the response rate, the B-cell depletion is in the range of the 90s and above, which is good. So the question would be, how do you translate this into clinical practice? There have been, I think, reached phase 2 trials in this particular drug, and actually the response so far has been good, especially in regards to the higher kidney response. So it's something which in the future is something which could be most beneficial for our patients. Voclosporin has actually been approved for lupus nephritis, and actually it was based on the Aurora studies, and actually the response was actually very good when compared to the placebo. One question I'm sure I'll be asked, what is the role of the other cyclosporine inhibitors? To be honest, first and second generation, not that good, because especially the risk of toxicity in terms of the GFR, hyperglycemia, hypertension. The voclosporin is a third generation cyclosporine inhibitor, and actually the response is better. There are fewer side effects. So this, but we still don't have long-term data on lupus nephritis. It's something which we learn as move along. And that's the first and second generation, not that efficacious in terms of lupus nephritis. So another drug is anifrolumab. I hope I've said it well. This one now targets the interferon pathway. In terms of its response, so far has been encouraging. It's something which, in terms of response actually measured in terms of reduction of corticosteroid dosing and flares and all that, actually is shown to be very beneficial. And they've tried a couple of doses here and there. And in terms of its response also, as you can see across the board clinically, from neutropenias, musculoskeletal, immunology, hematological, vascular, renal, which is very, very crucial, especially in our sector. In the TULIP 1 and TULIP 2 trials, actually has shown a lot of benefit. It also helps in terms of reduction of corticosteroid use, because like corticosteroids are associated with a lot of cardiovascular events. They'll be able to reduce the amount of steroids that the patient will use at the same time flares. So this is something which is encouraging. We're hoping to see what will happen in the future for this particular drug. One major drawback, because of the interferon pathway blockage, is the increase of herpes zoster. It's something which is being looked into, though they're saying it may be used not to drug discontinuation, but something which I think in the near future we'll be able to get a better answer in regards to this particular side effect. So other drugs that target interferon pathway largely unsuccessful, tabalumab and rodalizumab. So as you can see, it's very frustrating in terms of getting a proper treatment for lupus. Something which has been tried is the BIB059. Still doesn't have a name, but it's a monoclonal antibody targeting the dendritic cells, especially for cutaneous lupus, has shown some encouraging results. Class A is a disease activity index for cutaneous lupus. So as you can see from the charts there, that there's actually been some improvement. So this is something which in the near future will have some promise for us. One other pathway that's been targeted is the JAK pathway. Why? Because there's a lot of associated JAK pathway with a lot of the autoimmune diseases, and they've tried tofacitinib, baricitinib, but I think of the rest, I think baricitinib is one that has shown a lot of promise. But in terms of application to clinical setup, largely not the best. So something which I'm sure in the near future maybe somewhere where at a potential target for lupus. Other investigational drugs, we borrowed some from the multiple myeloma, the bortezomib and the ixazomib, though response not that well. But bortezomib showed some good response. The major issue with bortezomib was actually side effects. That's why it was discontinued. So ustekinumab blocks interleukin-12 and interleukin-23. These are very interesting because initially when they started at week 12, which is early in the drug, they showed some very nice response. People were excited. But by the time we reached week 24, nothing much was observed between the placebo group and the people on it. So it's something which has been largely a disappointment. I think more needs to be done to understand what exactly happened here. So as I'm finishing, sorry, I'm rushing because of time. What are the treatment strategies for systemic lupus erythematosus? The thing is, first of all, active disease, you treat to target. So if it's high disease activity, whatever you want to either target either remission or low disease activity. Once you are there, you minimize the amount of steroids you give the patient. Once you get there, you reduce or stop the immunosuppressants. The only thing is getting a third step might be a challenge in terms of reducing or stopping the immunosuppressants because of the risk of flares and everything. And as you can see, the time duration is a long time. And in theory, yes, they're saying 4 to 6 months, 1 to 3. But the thing is, in theory, it's not as easy as it looks because flares happen here and there. But what has been shown to be helpful, especially measuring this activity every 3 months, and they recommend is like the hemogram, which help you there, urinalysis can help you there, kidney function test can help you there, complement C3, C4, double-stranded DNA can actually be useful in terms of measuring this activity every 3 months. So reasons why we hate lupus, mysterious disease, sometimes can be difficult to diagnose, disease activity is difficult to measure, pain fatigue is something which is always a challenge, and there are no direct answers to pain and fatigue. We encourage many things, but to be honest, it's a very difficult thing. Prednisone is something which is difficult in our patients off because they're very highly addicted to it. Why? It's quick onset of action, it's convenience. Sometimes patients if I take the prednisone vis-a-vis taking the DMARD. Another thing is activity for lupus nephritis is a problem. Remember, most of the patients will get atherosclerosis. Thrombosis is also still a problem. So with the new targeted therapy, things hopefully are getting better because now we're able to target specific pathways. They're a bit expensive. And actually for now, a lot of them take, for example, like the lilumab and also the rituximab are actually used for when people have failed the conventional treatment. So in terms of what has been encouraging, the B-cell pathway has been really studied a lot. And it's something which will give us hope. T-cell, not that much. But remember that some of them are also failed, and partly because of the trial design and all that. I know some of the future trials, take example then for belimumab, nafolimumab, try to address that. In terms of the B-cell depletion and safety, because there have been issues that if you take out the B-cells, what about immunosuppression and all that, obituzumab actually answers some of those because the risk of infection was necessarily higher in those patients who had been B-cell depleted. In lupus nephritis, belimumab, cyclosporine are actually approved. There's a drug in the make, daratumumab, has shown some promise, but much needs to be done. Neurolupus is a very difficult one, very, very difficult one. And prognosis is still poor, much still need to be there. You notice I didn't mention about that. Fatigue is also a problem. I think for now, the thing is pushing for combination therapy because as we're seeing, the disease is very heterogeneous, multiple organs are involved and multifactorial. And then also, take for example, like the aflibercept, immunosuppression, but the risk of infection. Sometimes we may be so aggressive in trying to control the lupus to put our patients at what? At risk for infection. Remember also research and the federal drug price cost as an issue. Take for example, like the belimumab, rituximab, these are very expensive drugs. Not many people can be able to afford that. So hopefully the better understanding. I think we are still far from multiple personalized therapy for lupus, but hopefully in the near future, as we get a better understanding of the disease, things will get better. And I think I'm done. Thank you.
Thank you very much, Dr. Eugene, for the excellent presentation. Updates of lupus is always this way because there are new drugs. Very frustrating sometimes because people put in a lot of effort and time and it's not successful. But we are grateful that we have new agents and that studies are still going on and there's promise for the future. So thank you very much for exhaustively covering this update talk. Mine again is to introduce the father of rheumatology in the country, a gentleman who has seen very many lupus patients, who's going to talk to us about lupus and arthritis, Professor Modioyo. Prof, welcome. And kindly share your slides.
Good evening. Trying to put you on the slide here.
Good evening, Prof. You're loud and clear. Welcome.
Yes. Yes, good evening, ladies and gentlemen. I'm very happy to have been allowed to speak on managing musculoskeletal issues in lupus during this World Lupus Day. The World Lupus Day this year, our theme is fighting lupus together. And this is a special day for lupus patients and their caregivers, and is celebrated every 10th of May for the past 17 years to raise awareness about symptoms and health effect of lupus, not only among healthcare workers, but also among the healthcare givers, and patients, and everybody who is affected by lupus. The reason why lupus is important, Eugene has talked about why some people hate lupus, but why we must love lupus is because it affects the young people, young girls, who should be economically productive, who should be hanging around with their age mates, but are unwell in a hospital or taking multiple drugs, and they are sick when their age mates are not sick. And this is the importance of lupus and this day that we are celebrating. I will talk about the musculoskeletal issues, and the musculoskeletal involvement involves arthritis, arthralgia, myalgias, there's synovitis, fibromyalgia, osteonecrosis, and osteoporosis. But the reason why I thought that we should highlight this is because musculoskeletal involvement affects 50 to 90% of patients with lupus. But only arthritis is included in the classification criteria for lupus. Though there are inflammatory causes of musculoskeletal disorders, which is arthritis, tenosynovitis, myositis, myalgias, and arthralgias. In early lupus disease, sometimes it's very difficult to differentiate rheumatoid arthritis from arthritis due to lupus in the early disease. And many patients who have been diagnosed to be having rheumatoid arthritis have ended up having lupus as the final diagnosis. And the non-inflammatory causes of painful joints include fibromyalgia, osteonecrosis, and osteoporosis. And we'll just highlight one or two issues in the management of these conditions. This is the SLE criteria for management, for diagnosis of lupus, but I want you to notice that only arthritis, in spite of the fact that musculoskeletal involvement occurs in up to 90% of patients, only arthritis has made it to the diagnosis, the diagnostic criteria for lupus, and it still persists even in the new ACR-EULA diagnostic criteria. It keeps on pushing. It pushes itself there. The arthritis, and we see in lupus, is usually asymmetrical. Large and small joint polyarthritis is also symmetrical, like the one you see in rheumatoid arthritis. But the difference here that this one does not have demonstrable synovitis. And the other thing about the lupus arthritis, it is very, very painful, more painful than the one you see in rheumatoid arthritis. And when you do X-ray of the hands, for example, there's no radiographic evidence of erosive or deforming disease. The arthritis, even when there's some deformity, there's what we call a Jacquard arthropathy, which is a deforming arthropathy associated with the reducible deformity. The hand can form what looks like swan neck deformity, but you can pull it and it becomes straight, unlike the one in lupus, in rheumatoid arthritis. What are the issues with arthritis? When arthritis is there, there are serological markers of disease activity, such as worsening of leukopenia. If you get arthritis with worsening leukopenia, pneumochromic anemia, hypocomplementemia, and increased level of anti-double-stranded DNA, that's how the arthritis sometimes presents, together with worsening symptoms with serological markers of disease activity. So arthritis is one of the things that helps you to identify lupus flare. it shows that there's a problem in this patient when the arthritis becomes profound. The other extraarticular manifestation which can be seen in arthritis and arthralgia is a rash. The rash coming back, the various oral ulcers that were talked about by Angela, myalgia just weakening, and clinically significant renal disease. So arthritis comes within the framework of everything that can go wrong with the lupus. So when a patient with lupus comes with arthritis, you must also look for markers of disease activity and all the other complications that come with the worsening of lupus disease. And you must make a differential diagnosis with the other causes of joint disease, like rheumatoid arthritis. There's a condition that we call the lupus syndrome, where the rheumatoid arthritis and SLE coexist. The lupus and rheumatoid arthritis coexist, and you must know what is the difference between these two. Sjogren's syndrome can also present with arthritis and a positive antinuclear antibody, and you may confuse it with lupus. Then there are various bacterial and viral causes of joint inflammation as listed there. Parvovirus, acute hepatitis B infection, rheumatic fever, and hepatitis C. Very soon, Eugene will tell us whether COVID-19 will find itself in this list. So the management of arthritis and arthralgia is just the same, anti-inflammatory medications, and I put their GI protection as is significant because we do not want to add these patients other comorbidities like this peptic ulcer disease. Corticosteroids, as advised in the presentation by Eugene, least amount for a short time. And when you are going to use corticosteroids for a long time, you must also protect the bones using bisphosphonates, calcium, adequate calcium intake, and vitamin D, as was well articulated by Angela. Antimalarial drugs have been found to be very useful in patients with lupus arthritis, and this is one of the indications for using hydroxychloroquine, other than the other benefits that have been well documented. That here we use hydroxychloroquine, which is mainly used in the American people with American orientation. Chloroquine is mainly used by the Europeans, but whichever you choose to use, you must have annual or biannual eye exams, because the biggest fear here is retinal toxicity. And immunosuppressive agents can also be used, that can be used for management of lupus arthritis. Whatever drug that you use for managing lupus flare, is used for managing arthritis, because arthritis, when it comes, is a sign that the disease is active and there's a flare, and it often is the first indication of a flare. And we can use all these. The drugs that are listed there are all available in this country, including belimumab. Jean said that belimumab was not tried in Africans. Actually, when belimumab trial was going on, they needed blacks to be recruited in that trial, but South Africa and Kenya were included. But because of paucity of studies and paucity of documentation, a suggestion came that lupus does not exist in Kenya, and they will have to send somebody to confirm that the diagnosis were made is correct. And the study was withdrawn abruptly by GSK after getting ethical approval in the country, and that's how things go. The other issue, musculoskeletal issue in lupus, is tenosynovitis. This inflammation of the tendon sheath, tendon rupture, unlike rheumatoid arthritis, tendon rupture here is uncommon. And the management is by the same medications for arthritis. Sometimes you can give local corticosteroid injection for the flexor tendon sheath as appropriate, as the way we give it in rheumatoid arthritis. Then myalgias and myositis, these are just muscle inflammation associated with pain. Sometimes you get objective weakness, increased levels of muscle enzymes, and severe proximal muscle weakness. It is not unusual to get a patient with systemic lupus erythematosus coming and presenting like a patient with dermatomyositis. We treat them as such, but we need to exclude other causes of muscle weakness like thyroid disease, Chronic steroid use, which is common in this country on patients with lupus, is a common cause of muscle weakness, and use of colchicine and statins. And statins are often used. And I've seen a growing use of colchicine, especially in patients with lupus with some form of chronic inflammation. There are people like using colchicine, and these can cause muscle weakness in these patients. And the treatment for myositis is just the same as we do for inflammatory muscle disease: high dose of steroids, immunosuppressive therapy, and proximal muscle strengthening exercise. Although the medications can stop inflammation of the disease, there's nothing that can take the place of muscle strengthening exercise. And physiotherapy is part and parcel of management of patients with any form of weakness. The other thing that we need to look for is osteonecrosis, which occurs in 3 to 30% of SLE patients, and is associated with steroid dosage excess of 20 milligrams per day. And you suspect it in a patient with lupus and Raynaud's phenomena, lupus and hyperlipidemia, those who are using anti-cytotoxic drugs, and patients with antiphospholipid syndrome. And it often involves the hip and the knee. A patient comes with an excruciating pain of the knee or the hip, and it's a very, very common complication in lupus. And sometimes you may have to do an MRI of the painful hip, painful joint, to make a diagnosis. And MRI is the study of choice in making a diagnosis of osteonecrosis. Sometimes when a patient comes with painful hip and you ask for an X-ray, ask for an MRI, you are brought back that you should do X-ray first, and when you suspect something, you move and do MRI. But MRI is the study of choice. Like even, for example, in the back pain, MRI is actually a study of choice. So it's the study of choice for making a diagnosis. How do you treat osteonecrosis? Joint unloading, analgesic. Bisphosphonates have been tried, but we can use, it's a surgical cork decompression and joint replacement. This is one of the areas where we give joint replacement even in a young person, because there's nothing more you can give the patient with osteonecrosis of the hip joint once, even if they're young and they have lupus. Fibromyalgia is a common cause of pain, and I don't want to dwell at length on fibromyalgia. We have an excellent review of fibromyalgia in the current issue of the African Journal of Rheumatology, and I advise anybody who is here to get that one and read about fibromyalgia. Only to say that is one of the commonest causes of pain. We have done studies fibromyalgia in rheumatoid arthritis, in HIV and diabetes. We have not yet looked at it in lupus, and I think one of these days we'll look at it. But the management here involve physical and pharmaceutical measures, restoration of normal sleep, aerobic exercise program, tricyclic antidepressant, selective serotonin reuptake inhibitors, and pregabalin. This is where a patient comes with pain, and even give NSAIDs, you give steroids, immunosuppressant is not responding. You should start looking for fibromyalgia and manage it accordingly. Otherwise, thank you very much. And just to let you know that the 10th AFLA Congress was meant to be this year in July 2021, but because of the issues of COVID, is going to be there hopefully next year in March in the city of Mombasa in Kenya, the African Conference of Rheumatology, and I invite you to this conference. Thank you very much, and may God bless you.
Thank you very much, Prof. Excellent presentation. Musculoskeletal aspect of lupus, very well covered. Much appreciated. Our next speaker is Dr. Beril Ganda. She is a rheumatologist covering the whole of Rift Valley, all the way to my homeland, Lodwar, and places like that. So she's doing great work there, and, taking care of the patients from that area. She's going to give us a talk on lupus, fertility, and pregnancy. Welcome, Dr. Ganda. Kindly share your screen. Thank you. Sorry, I will share the slides on behalf of Dr. Ganda, but kindly allow Dr. Ganda just to give us a highlight of our presentation as I get our slides and share. Dr. Ganda, please proceed.
Good evening, everyone. Dr. Itao, can you hear me?
Yes, I can hear you loud and clear. I can hear you loud and clear.
Okay, sorry for that mishap. I thought I would be done by now. I've just been called back to work, so I'd have to give this talk from a place I'm not used to. I'm in the isolation ward. I'd like to join in celebrating the World Lupus Day and appreciating everyone who is here to listen to this talk and to all the talks that have been there and who have walked the journey with the lupus patients. And if there are any lupus patients among us, I would like to celebrate all of you for walking this tough journey and to reassure you that we are together. My talk is supposed to be on lupus, fertility, and pregnancy. And that is quite a wide talk. So basically, this is about reproductive health in women. So I'll just dive in directly to the talk and be able to summarize in a short time. I have no conflicts of declarations to make, neither my name, no clinical trials to be talked about, nothing to declare. And the recommendations that I'll be talking about are from experts who have come from a consensus, having put together evidence approach studies. So there's no specific study I'll be quoting. I'll just be quoting mainly recommendations that have been given by the European Alliance of Associations for Rheumatology and other rheumatological associations. The objective today mainly is to help to inform physicians or to help physicians who are taking care of women with SLE and or antiphospholipid syndrome to facilitate the physician-patient communication. We really need to continue shifting from cautioning against pregnancy in lupus to embracing pregnancy in lupus. I know this has been a very sensitive topic and is usually a very difficult thing for the women in lupus because you have to make a decision on whether you're going to have a child or not, and whether this is going to be a normal child or whether the pregnancy is going to affect you or not. So reproductive health in lupus cuts across all age groups. Remember that SLE affects women in their childbearing age, and because of the unmet needs that probably we don't communicate about or the patient does not talk about, it impacts a lot. The fertility and the reproductive health aspect impacts a lot on the personal relationships and the decision of these women to have children. So the earlier recognition that we have nowadays and the advances in medical treatment have helped managing the fertility and the reproductive health aspect in women much better. But it's always a multidisciplinary approach. We cannot do this without the obstetrician and the gynecologist, and we can't do this without the pediatricians. We can't do this without the counselors. We can't do this without help from everyone. So the scope of the reproductive health in SLE includes mainly the effects of pregnancy on the maternal disease. It also includes the impact on the maternal disease on the fetal health, on the baby that she's carrying. The safety of the medications during pregnancy and breastfeeding, assessing the fertility and the feasibility of assisted reproduction in these ladies, which contraception to use at what point in time, and also the management of menopause and the surveillance against malignancy. So you can see it cuts across a lady's health all the way from young to elderly, but today we shall only focus on 3 issues. So pregnancy drugs were talked about recently, so I decided let me start with the fertility issue as we go towards pregnancy. So what happens in fertility in patients with SLE, in women with SLE? There are very few studies that have assessed fertility, but until now, there is no concrete evidence to show that SLE per se as a disease will affect the fertility of a woman. However, there are aspects of SLE which can negatively impact on your fertility, and this can be active disease, active lupus nephritis, which is usually a very, very detrimental disease, and use of immunosuppressive drugs. All this might negatively impact on fertility. Alkylating agents like cyclophosphamide are known to cause menstrual irregularities. We know that they can cause premature ovarian failure, and all this is age and dose dependent. So we have to do a risk-benefit balance when we are using gonadotoxic drugs, mainly to know whether do I really need to use this drug at this point in time? Is the patient informed? And how better can I preserve the fertility of this patient when I'm going to use this drug? But similar to the general population, patients should be counseled on fertility issues, especially the negative impact that comes with increasing age, because the SLE patient might wait and say, let me wait and get better, let me wait and get better. But just like with the general population, there's a negative impact with increasing age. And then there are all those other lifestyle issues that can affect your fertility, like tobacco use, alcohol use, which is discussed with your physician. When it comes to fertility preservation, again, there's nothing specific about SLE, but it has been found that because of the multiple risk factors, patients can be encouraged to preserve their fertility at a younger age. The earlier you start, the better. As much as there's limited data, there's a little that has been said about using the cryopreservation, just like the general population, and you preserve your oocytes. And usually, mostly studied way of preserving is to induce the gonadotropin releasing hormones to induce the oocytes, and you save them where you can afford, where it is accessible. This is now accessible and manageable in our country, though it's very expensive, but it's always good that we give patients these options early, especially if we are going to give the toxic drugs. Assisted reproduction techniques, evidence and efficacy on this in SLE is only from observation studies. And yes, it does exist. The success rate is not any different from that of the general public, unless there are those negative factors that I had discussed earlier. Success rate is just like the one of the general public, that's 30%. However, we have to remember that those with on antithrombotic treatment and all those people with antiphospholipid syndrome or positive antibodies are always at higher risk of anything to do with reproduction and loss of pregnancy. So specific protocols will be tailored to these patients depending on their state of disease at that point in time. If the patient chooses to use the natural cycle, which is another option that they can be given, the rate is just as low as the general population, but that is an option that can also be discussed with the patient once they've been given all the options that are available. So what I'm trying to say is that assisted reproduction technique is tailor-made towards each individual patient at whatever time they're presenting to you, at whatever stage of the disease they're presenting to you, and you balance out the safetiness and versus the effectiveness of all the options. So what are the contraceptive measures that we give to these patients? Contraception counseling is one of the things that you have to do as a physician or a person who is in contact with SLE women. It's the first thing you discuss, especially if they're at reproductive age. The main thing here is we want to prevent unwanted pregnancies during the high disease activity periods. And we also want to reduce the intake of the teratogenic drugs. So the type of contraception, again, is tailor-made towards each individual patient. You look at the individual risk factors, you look at the general risk factors like hypertension, obesity, tobacco use, family history of hormone-dependent cancers, and then now we go to the disease-related risk factors, particularly disease activity and thrombotic risk factors like antiphospholipid antibodies. In general, the intrauterine device has been found to be the safest. In fact, that is what I offer to most of the patients who come in. But the funny thing is that when patients come in and we discuss contraception, especially the young ladies of childbearing age, whenever we discuss contraception, it is usually a blessing that during their next visit, they're usually expectant and happily so. So I don't know how this has worked in other practices, but the more we discuss contraception, the more the babies we get. But I must report that in most of them, we've had good outcomes of the pregnancies. The copper IUD is the safest in what has been used because it does not produce any of the of the hormones. Levonorgestrel containing ICDs can also be used and should be considered against the benefits of the hormone because the hormones can be thrombophilic. So again, we look at benefits versus the risk. The safety of the combined pills in a patient with inactive or stable disease, again, is discussed. And if the patient is negative for the antiphospholipid antibodies, this is a safer option, but again, discussed with the individual risk factors, as I had mentioned earlier. Women who have positive antiphospholipid antibodies, with or without the syndrome, should be discouraged for anything hormonal in terms of contraception. Pregnancy and SLE. It is very, very important to do preconception counseling and risk stratification. This is very crucial. Before the patient decides to get the baby, it is important that they discuss the pregnancy with the physician so that you can have the drugs and the process tailor-made to the patient. So what are the risk factors in pregnancy in general that we fear when it comes to SLE patients? Active SLE or flared SLE can cause preeclampsia, it can cause eclampsia, it can cause early fetal loss, it can cause preterm delivery. Active nephritis can cause adverse maternal outcome. This has had a lot of evidence coming with it. Hypertension can cause preeclampsia, it can cause preterm birth. Steroids have been shown that at a very high dose, maintenance dose, can cause preterm birth. Discontinuation of HCQ. HCQ is one of the drugs that you want to have on board in patients who are expectant, can cause SLE exacerbations during pregnancy. SLE as a disease, whether flared or not, is already a risk factor in the pregnancy, and it can cause prematurity and all those other risk factors that I've talked about up there. So if you have to have a checklist, this is a checklist that has been given for physicians to use for counseling and risk stratification in women in SLE. And all the time that they come into the consultation room, these are the things that you're going to check to see if you are having a flare and what to do about the flare or how well the patient is progressing. SLE activity and flares in the last 6 to 12 months, it is said that the best time for a patient to carry a pregnancy is when they have been free of flares for at least 6 to 12 months before conception. Lupus nephritis, any history of lupus nephritis or active nephritis during conception is a risk factor. Serological factors like C3, C4, anti-double-stranded DNAs, which we use for disease activity, should be monitored, where if the C3s and C4s are going down, because naturally with pregnancies, you expect a low or high normal of C3, C4, anti-double-stranded DNA titers, if you suspect, again, you correlate it with the clinical symptoms. Previous adverse pregnancy outcomes should also alert you as a risk factor. History of vascular thrombosis in this patient, their antiphospholipid profile should be checked. Anti-Ro and anti-La antibodies, and we know that these ones increase the risk of congenital heart block. End-stage organ damage and associated comorbidities. SLE as a diagnosis by itself, again, is a risk factor. And down there, the risk factors that I've talked about are what I had said earlier on all the complications that can happen to the mother and the child, and the mother who has SLE. Then we have the general risk factors, which include the maternal age, the arterial hypertension, diabetes, overweight and obesity, thyroid disease, nicotine and alcohol use, immunizations. So all these have to be checked as a counseling and risk stratification list. That is just a table to summarize what I have talked about and what needs to be checked during the patient's reviews. Just to talk about the general things is that we should remember that there are those physiological changes that occur during pregnancy, like fatigue, arthralgia, myalgias, soft tissue edema, melasma, which you might confuse again for the Malala Rash, anemia of hemodilution, gestational thrombocytopenia, increase in ESR, increase in serum C3, C4, low-grade proteinuria, increase in GFR. So remember that the physiological changes, which you must check against the changes that occur in SLE, that would alert you that we are having a flare, or would alert you that we are having a complication in pregnancy, and we should score. The other important thing we should know is that when it comes to disease activity, there are disease activity tools that have been tailor-made for pregnancy. We know the SLE die, and now we have it in pregnancy. And other indexes that can be used in pregnancy that have been made for physicians to use during the patient visits, which is at least 2 to 8 weeks apart. So it's good that we know those changes. What do we do during the pregnancy? We do fetal surveillance. What are we looking for in fetal surveillance? The first thing we should do is that we should know that this is a risk pregnancy, and we follow the usual protocols of high-risk pregnancies, especially that come with hypertensive disorders and placental insufficiency. So this we do with the obstetrician and gynecologist. We adjust the frequency and the modality of the fetal surveillance according to what we find. So the most important thing that we do during fetal surveillance usually is the Doppler ultrasound of the Dopplers of the umbilical and uterine artery. This will tell us about the state of the fetus, whether the fetus is developing intrauterine growth retardation, whether we are at risk of getting preeclampsia. And the earlier you start it, the better, because it will inform us on whether to carry this pregnancy to term, whether to deliver this pregnancy early, whether to get rid of the pregnancy somewhere in the middle, because the child has many complications. So it's important to do fetal surveillance. Fetal echocardiography, a very difficult and complicated but doable investigation, mainly to check on the congenital heart block that affects children of mothers with lupus, especially if they have the Rho and La antibodies. Most of these patients have been found to have a 16% recurrence rate if they had had a previous baby with a congenital heart block. However, if they have not had a previous baby with a congenital heart block, it is good to inform the patient on the risk. The risk has been found to be low, but however, it's good to inform them, because what has been found is that most women will be acceptable to having a fetal echocardiography frequently, because they would like to also know what is happening and to be sure and to be reassured about the pregnancy that they are carrying. However, you have to balance this against, of course, the cost benefit of doing this. Do steroids help to prevent the congenital heart block? Not really. Not many studies have been done, and it has not been proven. So again, there's a risk-benefit stratification there, mainly for congenital heart block, hydrops fetalis, and cardiomyopathy. Neurodevelopmental alterations have been found, but maybe Dr. Angela would tell us there's nothing that has been linked directly to SLE, or you would not know whether it is the SLE that caused it or it is a flare that caused it. So we can't really say that they do develop neurodevelopment alterations. Drugs for prevention and management of SLE flares during pregnancy. The drugs that we use is one drug that you want to have on board is hydroxychloroquine. This has been supported adversely in controlling disease activities and preventing flares during pregnancy. Preconceptionally and throughout pregnancy, it is important that you have the hydroxychloroquine on board. It's been found that it may prevent the congenital heart block. Now, the rest of the drugs, you have to do a benefit-risk assessment. Oral glucocorticoids, azathioprine, the calcineurin inhibitors, it's very important. They do control SLE activity during pregnancy and control studies though, but we do a benefit-risk ratio. When you have moderate to severe flares, you can use high-dose glucocorticoids, IV immunoglobulin, plasmapheresis can be considered. When it comes to cyclophosphamide, which is used mainly when you're having the lupus nephritis, it's very important to avoid it in the first trimester because the risk of fetal loss is very high. And this can be reserved for second and third trimester for refractory SLE. Belimumab, which has been discussed today as one of the main drugs in SLE, there's no sufficient data to evaluate the risk in pregnancy. So once again, when it comes to using belimumab, you want to do a risk-benefit assessment. MMF, methotrexate, and leflunomide are drugs to be avoided because they're known to be teratogenic. When it comes to the drugs that are used during pregnancy, once again, we have a lot of recommendations that have been published by EULA and other bodies that we should follow. Are there any adjunct treatment during pregnancy? Yes. When it comes to SLE with antiphospholipid syndrome, there's a lot of other drugs to be discussed. But when it comes to SLE alone, it's been found that low-dose aspirin has been used against getting preterm and severe preeclampsia in patients who have autoimmune and non-autoimmune disease. Now, when it comes to the SLE, especially those with lupus nephritis and antiphospholipid antibodies, they have a benefit of using low-dose aspirin, especially if you start it before 16 weeks. Are there other drugs to be put in? Just like the general population, you want to include calcium, you want to include vitamin D, you want to include folic acid for SLE patients, especially if their vitamin D levels are low, especially if these patients are receiving steroids, which is going to reduce their calcium and make the bone loss, and especially if these patients are on heparin. That table just summarizes patients who are going to be put on anticoagulants versus the dosage of anticoagulants. I don't think I will go in too deep into that. I was just given 15 minutes. What is the message that I want to pass to the SLE patient is that as a woman with lupus, it is important to work with your doctor to monitor your reproductive health at every stage in your life, because at every stage in your life, there are different needs and there are different drugs to be tailor-made to your needs. However, the most important issue for you to consider is that things will change, as I've said, with age. At menopause, there are different things to be considered. Reproductive age, there are different things to be considered. Young girls who want to preserve the oocytes. In conclusion, most women can successful pregnancies. Just give me a minute. Most women can have successful pregnancies. This is very important for all of us to know. And measures can be taken to reduce the risk of adverse maternal or fetal outcomes. It's very important to do family planning and to discuss it with your physician at every step. Health professionals should support the patient and her family in their decision regarding family planning by discussing individual pregnancy risks, every lady with their different risk factors. Just to conclude, I want to challenge all of us right now, because I don't think we have a SLE pregnancy registry. It would be important for us to maybe start one, keep one, know what our outcomes have been, know how our patients have progressed, so that we can also be able to publish our own papers and know how SLE behaves in our local population. Thank you.
Thank you very much, Dr. Beril Ganda, for that exhaustive presentation on pregnancy and fertility and lupus. Thank you very much. Now we are moving to the next and the final part of our World Lupus Day webinar, and it will be to answer all the questions that have been asked, and I will request all the panelists to join us. The team that was to lead this is Dr. Angela Mcgowan and Dr. Simani is not here with us. Dr. Mcgowan, you're ready to lead this question and answer session. As she prepares to join, just a comment on belimumab. I'm happy to say I've had one patient on belimumab, unfortunately just one, we didn't get any more, who has had this medication for the past 4 years. And apart from a slight soft tissue infection, she's tolerated it quite well, and it has made a great difference to her quality of life. Yeah, so as a lupus targeted therapy, belimumab has added value to her life, and she has been on it, I think, for 4 years. And the main adverse effect that she got in the past 1 year was a recurrent soft tissue infection. But we also found out that the risk factor for that was that she was on a low dose of steroid, but it was most probably the steroids, because once we tapered it down, then the infection rates became less. So Dr. Mcgowan, I'd like to hand over to you, but if you need my assistance, I'll be here. Kindly lead us on the question and answer session.
Okay, thank you, Dr. Etau, and once again, thank you to all the presenters and all the participants. So we'll go straight into the questions. Peter Nyakia asks, is the lupus retinopathy reversible? So Mr. Nyakia, yes. In this particular case that I presented, she needed, I think, about 2-3 doses of rituximab and cyclophosphamide, and you know, we were able to successfully reverse the retinopathy. The involvement of the respiratory muscles, we were also able to overcome that. And she was up and about and back in school. And this was a patient who was managed together with the team at Nairobi Hospital, together with my colleague, Dr. Lawrence, and myself. Elizabeth says, hello, excellent presentation, Dr. Mcgowan. Interesting to listen. Any support groups for parents to children with lupus, considering the socioeconomic status and challenges? Liz, this is really a phenomenal question. It's the reason why we are doing this. It's the reason why, under the leadership of Dr. Etau, they had a session during the day to help raise awareness for this. So there is a lupus organization for patients in Kenya, and they have held, I think I even saw a poster of an event they were holding around this time. And it's led by a lady, I think, Jean Banda. So if you Google, definitely it is there, okay? All right, next we have, let's see, Caleb, I think, if I got, yes, Caleb Obuya. Caleb Obuya says, great presentation. He says that around the lake region, he's noticed a number of people coming to the pharmacy complaining of arthritis. How best can it be managed? So Caleb, what I would advise is that ultimately, the thing that you can do safely is to give non-steroidal anti-inflammatory drugs to relieve their symptoms. But it will be important to reach out to the rheumatologists, even if it means having a virtual consultation, to try and narrow down what exactly the situation could be. At least I know in pediatrics that's what happens, because we're only 2 in the country. So we get a lot of phone calls from our colleagues, and we discuss with them. We go through the cases with them to try and work out what the problem is. If it's an adult patient, you have the privilege of many more other colleagues whom are on this call. I encourage you to reach out to them to address these matters. Beril, I think this might be for you. They say, good presentation. Which immunosuppressants do you recommend in pregnancy in addition to prednisolone? Beril? Is Beril still there?
Is not there. We could ask Prof. Oyo to respond to this.
Professor Oyo, your thoughts?
Yes, yes, thank you. Apart from steroids and hydroxychloroquine, the one which is safe and is safely used in pregnancy is azathioprine, and that is one of the issues, is one of the drugs that are safe and recommended in pregnancy, azathioprine, especially when there's a flare of disease, because you notice that many of them are not recommended. But while I'm at this, I need to say that one of the breakthroughs in lupus is not in new drugs, but judicious use of other drugs which have always been there. Like the reduction of the steroid dose and the judicious use of steroid has increased the survival of patients with lupus, because many of them were dying because of complication related to steroids. Second, it has been observed that we are underdosing our patients with azathioprine. We are not using enough dosages, and that's why we end up with the flare. So we need to use optimum dosages of azathioprine and reduce. When you start steroids, you should consider when you are going to stop it, because injudicious use of steroids is one of the leading causes of mortality in patients with lupus. But again, it is the one you use when you have faced with life-threatening issue.
Prof, that point you've mentioned is really, really fundamental, that, when as rheumatologists, when we're using steroids, we use them with a plan. It's not that we put our patients on steroids for eternity. So thank you really, Prof, for highlighting that. This next question, maybe I'll direct it to Dr. Eugene. Is it wrong for a patient to take the Deflazacort on and off, depending if she has frequent flares or not? What are your thoughts, Dr. Ari?
What I usually advise my patients is that if you feel there's a need to use any steroid, the Deflazacort is a steroid on and off, it means your disease is not well controlled. So it only means you need to go back to your rheumatologist and see if you can get an appropriate combination of treatment, because steroids are, like Prof said, a lot of the issues surrounding steroids is infections, death, and all that. So if we are using it on and off, it means your lupus is well controlled. you need to talk with the rheumatologist and see what other options that you can add.
Available.
Yeah.
Good point, Dr. Thank you for that. The next question was directed to me by Dr. Yosa. Dr. Angela, management of leukopenia, infocytopenia with lupus. Dr. Yosa, thank you for your question. So when you see leukopenia in lupus patients, it's often a marker of active disease, uncontrolled lupus. So the thing there is therefore to optimize your immunosuppressive therapy to try and get better control of your lupus. But as you do that, we're always treading very carefully because we know the leading cause of mortality in lupus patients is infection. So before we become very aggressive with our immunosuppressive therapy, we are always screening to make sure that we are not sitting on an infection. And it's one of the markers personally I use, especially as I follow up patients to see if they're responding to therapy. Another attendee asks, can children be put on long-term corticosteroid therapy? The answer is yes, but to echo the sentiments of Professor Oyo, when we start our patients, pediatric lupus patients on steroid therapy, just like our adult colleagues, we start them on therapy with a plan. Personally, with lupus patients, I aim to get you off the steroids between 6 months to a year. If I'm not able to do so, just as Dr. Eugene Kalman has highlighted in the previous question, I relook again at the disease-modifying anti-rheumatic drugs I'm using because we don't want them on steroids for too long just because of the morbidity, as has been highlighted by my colleagues. Dr. Eugene, this is for you. By our attendee, Ms. Munani Mutuku, kindly elaborate on the success rate of rituximab in treating lupus nephritis. I've just been recently put on it by my nephrologist. Dr. your comments to Ms. Mutuku?
So I'm not sure the indication for the rituximab, but from the research that's available, in terms of first-line treatment, in terms of rituximab for lupus nephritis, from the data and from the trials, they are not that successful. But for refractory meaning that a patient has been on steroids, maybe mycophenolate, and also been on azothioprine and have not responded well, the response has been better in terms of reducing the steroid dose. And the challenge we have some of the studies have used a small sample size, 60 cases, 90 people, but largely the success has been actually good. Some studies have put up 90% success rate. But the challenge is the sample size is a bit small. But in conclusion, what the expert says is that in terms of first-line therapy, it may not be the best, but refractory, where maybe the patient, where the doctor feels that it can be an add-on therapy to the existing treatment and everything, the outcomes are usually better. Yeah,
thank you, Dr. Another attendee, and this one maybe Dr. Tao, I'll direct it to you. They say that I have a comrade who had SLE. She conceived, but she did not make it. She passed on. Our sincere condolences. Is it advisable to cancel patients while suffering from this disease to delay conception? Your thoughts, Dr. Tao?
Thank you, Dr. As Dr. Beril correctly put, of course, the decision to get pregnant is an active decision where the patient and the rheumatologist and attending physician must discuss and agree the appropriate time for it. So remember that she talked about low disease activity or remission. So that will be the thing. I don't know what context led to the death of this patient. Sometimes it may not necessarily be lupus related. It could be something else, either clot or postpartum hemorrhage or something else. I'm not sure what is the cause of death. But remember that even still in pregnancy, the causes of death are the lupus disease activity, infections, thrombosis, and of course the other pulmonary eclampsia, hypertension related to pregnancy. So it will be difficult unless one knows the case history
Circumstances,
to adequately answer the question. But for sure, one requires to have a low disease activity or remission prior to conception.
Thank you, Dr. Tao. The next I'll direct to you, Professor Oyo. And this is from our colleague, Dr. Mondi Ogutu. He says, in patients with RPL, I'm not sure what that stands for, we are finding increasing numbers of patients with positive anti-nuclear antibody. Use of hydroxychloroquine and prednisone are important in the luteal phase of the stage. Use of prednisone until 12 weeks and then taper is beneficial with no effect on the baby. So the question is, should symptomatic patients with positive markers be on medication? Professor Oyo, any thoughts on this question?
I think there are patients that we have been looking at with Professor Mondi Ogutu and Dr. Ngech, and the usage of any patient with the antiphospholipid, the markers of antiphospholipid syndrome or recurrent lupus pregnancy loss. When we start them early on hydroxychloroquine, even preconception and steroids, the outcome has been good. But right now we are busy looking for a postgraduate student in obstetrics and gynecology, so that we can look at the outcome of patients with lupus. What are the determinants of successful outcome versus adverse outcome? And I think once we succeed in this, we will be able to answer these questions with more courage. Thank you. But lupus is a study of lupus and pregnancy is a study of anything that can go wrong in pregnancy. As much as lupus, HIV, and TB and syphilis is a study of internal medicine, lupus and pregnancy is a study of complications of pregnancy. And if you know lupus and pregnancy, you know the whole of bad obstetric complication of obstetrics. Thank you.
Thank you, Prof. Jared Motuka asks, hello, is race a risk factor for SLE? Mr. Motuka, what we know is that among the Asian and the African population, SLE is more aggressive. But the unfortunate thing is that a lot of genetic studies have been skewed mainly to the Northern Hemisphere. So I think the onus is on us to also lobby and see how we can do more studies to address some of the genetic variabilities that put us at high risk. Another attendee says, good presentations, SLE is clearly an expensive illness. Does NHIF cover for any of the treatments other than dialysis? Dr. Ganga, would you, Kalman, would you like to respond to this?
Other than dialysis, I don't think NHIF does much, to be honest. I know civil servant cover can be able to get, but in general, NHIF cover, unfortunately, not. I don't know, maybe my seniors have more experience, but I've been trying, as I just want the group that maybe we should try and push NHIF to cover some of these things. I know they have a cardiology package, I think a renal package. Maybe some of us, we can approach maybe the Minnesota and see if we can get a rheumatology package in short. Maybe we can try and see if we can support. I know in some certain biologics, they give some small percentage like the infliximab. We have seen some patients who have gotten. But for SLE, to be honest, nothing much that I know of.
Dr. Etawu, your thoughts on the lobbying for a rheumatology package by NHIF? Your thoughts?
Yes, I think it's still work in progress. We were to liaise together and even formed a WhatsApp group, but we have not been active. I think it's something that we need to work on. Yes.
Thank you. Thank you, Dr. A question here by Ms. Mutuku. Where is Dr. Beril's clinic? I'm aware she works at the Moi Teaching and Referral Hospital. I don't know, Dr. Etao, Dr. Kalman, Professor Yo, do you know if she works anywhere else? I know she's based at Moi Teaching Referral Hospital and within those environs.
Yeah, she's based in Eldoret. But this is a question Mutuku can be given the directions later on. I think you can move on to the other question, the lupus. Yeah, the medical questions.
Yes. How is lupus in patients with HIV? Dr. Etao, would you like to take that one?
Yes, there have been There have been studies that looked at patients who have HIV and who have lupus. Unfortunately, most of the patients, the outcome wasn't too good. Yes, so unfortunately, the management of a patient who has HIV who develops lupus, of course, it's by case basis. Some of the patients we have had around have had very serious complications, including cardiac, renal. So it's been very challenging, and also the balance between the all the diseases, immunosuppression vis-a-vis the management for HIV. Yes, and if one knows a patient who has HIV and has lupus, then this is a patient that requires close treatment and follow-up by the rheumatologist and, of course, by the infectious disease specialist.
Yes. Thank you. Professor Yo, are there any specific lifestyle modifications you advise for lupus patients?
Yes, thank you, Angela. This is a question that was dealt with quite extensively in the afternoon symposium. But basically, we advocate for exercise. We advocate for stop smoking cessation. We advise maintenance of good lipid levels, because you know the biggest killer in the long term in patients is precocious atherosclerosis. So you want to eliminate all risks for cardiovascular risk factors, management of blood pressure, management of weight, management of cholesterol. You must have a good weight, exercise program, and the diet that will help you to control some of these issues. But the most important lifestyle modification is to take your drugs and maintain your regular appointment with your physician or rheumatologist for that matter.
Okay. All right. Thank you, Professor Yo. I think please reach out to the team that shared with you the Zoom link as you inquire about the CPD points. I see that's a point that has been raised here. There's one attendee who also is inquiring about their monthly cycle vis-a-vis the possibility of early menopause. So to Dr. Kalman, is there an association of lupus and early menopause?
There has been some research that showed that the risk of getting premature menopause is actually there from the drugs they take, the steroids and the immunosuppressants. So the risk is there. I think for such a talk, it's usually best if we see the gynecologist. They usually some more tests they can do them, but the risk is actually there. Yeah, the risk is there. Yeah.
Okay, thank you, Dr. So whoever posed the question, please link up also with your gynecologist. Dr. Eugene, a question to you: is the golimumab injection offer still on, where you buy one, get one?
Yes. It's still on. Golimumab is a special, like we call a biologic. It blocks the TNF pathway. It's useful in terms of rheumatoid arthritis, ankylosis, spondylitis, and therefore it's still there. But you buy 2 times and get the 3rd month free. So for those who feel need the drug, please contact any of us, the team here. We'll be able to at least link you up.
Dr. Angela, I think we have about maybe 1 more minute.
Okay.
Before we exhaust our time.
Okay, so maybe I'll see. There's one question here which I think really has an implication, and maybe Dr. Tao, you could take that question about brain fog. Would you advise patients to try and overcome brain fog, those who have got lupus?
So yes, brain fog is a significant challenge for patients who have lupus or develop this. There are several causes of brain fog. It could just be related to the disease activity itself. It could be related to fibromyalgia that can be coexisting with lupus.
Yeah.
And like we mentioned in the lifestyle aspect of the program, the stress management, the exercises, meditation, prayer, mental health, just general mental well-being, the role of psychotherapies, the cognitive behavioral therapies, appropriate dieting, of course, rational alcohol use, avoidance of smoking, all those factors that will actually worsen or alleviate the brain fog in this sort of patients.
Okay. So thank you all for your active participation, for all the great questions. And as has been stated, don't hesitate to reach out to the panelists. I know I speak for them when I say they're willing to assist in the event you encounter these patients with lupus. Thank you. Over to you, Dr. Etau.
Thank you, Angela. Thank you very much. And we are grateful, and we are coming for a very long day. It's been a long day for the rheumatology fraternity today, but we have come to a close, and we are grateful that we had this opportunity to celebrate World Lupus Day in this manner within this COVID-19 pandemic. And in closing, mine is to first appreciate the management of Kenyatta National Hospital for providing these platforms where we have had these patient sessions and we have had this evening symposium. Of special note, Dr. Kinudia, the head of research and programs, who is attending this, and we appreciate him. Dr. Amina, very dedicated from the first moment we started this journey. Nelson from the same department, who has worked very hard. I'd like to thank all our rheumatologists, Professor Oyo, Dr. Owino, Dr. Angela, Dr. Fred, Dr. Eugene, Dr. Beril. You have been very dedicated. You have taken your time. We have been together the whole day. I'd like to thank the patient societies, for especially Lupus Foundation of Africa, for participating, for the poster that they did make. I'd like to thank our patients who have been patient with us in the afternoon today, and they've been with us even during this evening symposium, and they've continued to fight this disease and conquer it in the various ways. You are our warriors, you are our soldiers, you are the ones all this is for. Thank you very much. And we'd like to thank all our medical colleagues, attendees, who turned up in huge numbers today. We appreciate your time, and thank you very much. So in closing, I want to say asanteni nyote. God bless you. Let's continue fighting this disease. Of course, we shall continue to conquer it. The questions, we are happy to have answered them. The ones which did not answer, we hope you will be able to get other opportunities. And we shall work hard to ensure that we come up with the registry for lupus, for pregnancies, and we shall continue with all the research. Thank you very much, and I will now request the team now to close this meeting. Much appreciated. Bye-bye and have a good night.